Hi, I'm Marvin Natowicz. I'm staff at the Cleveland Clinic, and I'm on the faculty as professor at Case Western Reserve University School of Medicine. And we're fortunate today to have with us Dr. Greg Holmes, who is chairman of neurological science and professor of neurology and pediatrics at the University of Vermont College of Medicine. Dr. Holmes is a well-known, very esteemed clinician and researcher in the fields of neurology, especially epilepsy, and has served as past president of the American Epilepsy Society and has received numerous awards and honors from many organizations for his clinical work and for his research. Today, Dr. Holmes will be talking to us about autism and epilepsy. There are several learning objectives for today's session. First, we'll review some important clinical issues relating to persons having autism and epilepsy. Second, we'll have discussion relating to selected important aspects of etiologies and pathogenesis of epilepsy in persons with autism. And third, we'll have Dr. Holmes speak to us about important gaps in our clinical understanding and treatment and in basic research understanding relating to autism and epilepsy. How do clinical researchers and how do basic science researchers, neuroscientists, study imbalances of excitation and inhibition? And how do clinical researchers and basic science researchers study networks, the functionality of networks, interconnectedness and abnormal connectedness within different regions of the brain, say in persons with autism or other neurological conditions?
Yes, so there's two ways of approaching it. One can use animal models, and then one can study individuals with autism and individuals with epilepsy. And as we think more and more about the connectivity of the brain, we can use a number of techniques. One is your standard EEG, but we use EEG more to look at how the brain is connected than just for spikes on the EEG. So EEG, and I'll come back to that, and then functional MRI can provide you a lot of information about...
Can you explain what functional MRI is?
Yeah, functional MRI is an MRI technique that basically looks at blood flow to the brain, and then brain parts that are activated have increased blood flow there and have a you can mark how how this is connected through the Bode signal between two different areas of the brain. So how active these areas of the brain are and whether they're active together or not. So you can have the individual do a task during the functional MRI. They can do a memory task. They can do a motor task while in the MRI scanner. But you can also do what's just called default modeling, where you just have the patient set there. And then you can look at the MRI and look at how different areas of the brain are connected looking at these pixels on the MRI scan to provide some information about connectivity there. And then you can take those measures and give them scores, and the different areas. You can look at the frontal part of the brain versus the temporal and different areas of the brain, and then compare that to neuropsychological testing afterwards to see if there's a relationship between like autism severity scores and this degree of connectivity. You can also do the same thing with EEG. I've been working with the group at National Institutes of Mental Health, and we're particularly interested in what the sleep EEG is like, and this is children with autism. And we, in this study, which is a really powerful study in that we had close to 100 children with autism, and we compared them with neurotypical children, and we compared them to children with developmental delay without any autism. And found that when they're sleeping, the brains of children with autism based on an EEG measure. It's called coherence. And this just refers to how waveforms in one part of the brain are synced with waveforms in other parts of the brain. And that's called coherence. So with coherence, a coherence score of 1 would indicate that an oscillation in the occipital lobe or the back part of the brain is totally in sync with an oscillation in the frontal lobe of the brain. And it's a measure of synchrony between different areas of the brain. And we found that children that had autism during sleep, particularly during slow wave sleep, where we're doing a lot of our memory consolidation is occurring, great deal of synchrony occurs. So their coherence scores were much higher than the children with developmental delay and without autism and the neurotypical children. So it was a pretty powerful marker as a group to indicate that the brain seems to be hyperwired during sleep in these children. We're just finishing a group of children now, toddlers, who we compared children that were developing language normally versus children that have delays in language. Not sure if all those children are going to go on to develop autism, but quite a few have. And again, this early EEG marker was pretty powerful as a group measure to distinguish between the children with autism and the children with that were neurotypical. I should say that this by no means is the answer to autism, and that there have been other investigators using fMRI, using magnetoencephalogram, which is similar to an EEG, although you use magnets to give you more of a three-dimensional picture of the brain, have had some differences, and they found that there are certain areas of the brain in which the coherence was decreased. But by and large, I think most investigators in the field that are using these techniques feel that there's in autism, there's an alteration and a connectivity in the brain. Working with the NIMH has been very useful because this may change over time, so that we're looking longitudinally at the changes in sleep over years, and that it may be one of these situations where maybe everyone's right, so that a coherence, especially in the very young children, seem to be overly connected. And there's also, some evidence that in children with autism, there may be some overgrowth of brain structures, particularly in the frontal lobes of the brain. And that's where we're finding our highest degree of coherences. That's where we're finding our highest degree of interictal spikes in those children that have epilepsy. So there may be something to that, but I think it's certainly worth pursuing, and it's a nice development as the field moves towards changes in connectivity in the brain. Now, having said that, for parents, it's very difficult for us to do a single EEG on a child and say your child has is likely to develop autism or not. So looking at group differences between groups is different than having a predictive test for an individual child. So we're not at that point yet.
From a very practical point of view, if a child has autism, what are the different circumstances when either the parents or the primary care physician might want to screen for epilepsy? What are the triggers to getting someone to someone like you, and how do you approach the screening from a practical point of view?
Yes, it's a great question, and it comes up very frequently in practice because, as part of the complex behavioral disorder these patients have, they can have very stereotypic behavior changes that may look to someone that's not familiar with epilepsy, such that they may be having seizures. A lot of the individuals with autism will zone out for periods of time, and people think, oh my goodness, they're having an absence or petit mal seizure. when in fact I think it's more they're just trying to break out of the system just to try to dissociate from the external stimulation. So, a few things to keep in mind. I think one of the most common ones are children with staring attacks. And you can have absence seizures in which the child simply stares, but that's actually unusual. Most children with absence seizures will have some degree of eye blinking, automatisms, little movements of their hands, chewing movements of their mouth. And there will be a rapid onset, offset to the absence seizure. The children that zone out with autism tend to have longer, I should say that typical absence seizure lasts less than 15 seconds. Children with autism tend to have episodes that last for minutes where they zone out. And the parents may wave their hands and touch the child and it still doesn't come to, but they don't do any other behaviors during that. So it's unlikely that those are seizures. And in fact, that's been studied pretty extensively. And most of the time when you have a child with just staring attacks that has autistic spectrum disorder, they end up not having seizures on their EEG. The other motor activity is sometimes can be difficult because sometimes in seizures you can have complex motor activity. But usually in epilepsy you have like either tonic activity where the child becomes very stiff and rigid. You can have a myoclonic activity, rhythmic jerking that's synchronous usually between both sides of the body. You can have drop attacks where the child suddenly loses tone and falls to the ground. They're usually more obvious and more distinct than the stereotypic behavior of hand shaking, for example, head bobbing, head banging, that type of thing. So I think, again, it goes back to the history. I think pediatricians are very good at distinguishing between seizures and autistic, the stereotypic behaviors in individuals with autism. But I think what we're doing now more and more, and the parents are very willing to do this, is they shoot videos of the child during the events and screen it with their pediatrician, or I spend a lot of time each week looking at videos sent to me by parents and whether I think they're seizures or not. And if there's a doubt in your mind, you usually go ahead and get the EEG on the child, and that should give you the definitive answer. But oftentimes we do not need to put the child through the EEG once we actually look at the behaviors that the parents are concerned about as well. Seizures, a lot of seizure types to children are postictal following the seizure. They'll fall asleep, be very tired. We sometimes get that history after a child with autism has gone through a series of repetitive behaviors, but that's again a little unusual for them to have a postictal or tiredness period after the event. So clinical history is critical, I think. And with videotaping now, it has become much easier. And if you need to do an EEG, you can do it. The one issue with EEG is it's sometimes, especially with the children, it can be a challenge to get the EEG on the children. So we like to avoid that stress as much as possible. But if there's a doubt, we would go ahead and get the EEG on the patient.
And, some persons with autism, more from the general population, I suppose, during an EEG recording, especially if it's a multi-hour recording, or an overnight recording, might rip off or lose some of the leads. Is it essential to have every lead in place to capture effective information, or can you still have some good information even if one or more of the leads might be have fallen off?
Yes, we can usually read through the artifact, and we put 21 electrodes on. So if you lose one or two electrodes, and they often come off the frontal part of the brain where the child scratches, we can get by with the EEG and feel that we're pretty comfortable It's not ideal, but we feel pretty comfortable, at least ruling out seizures or not based on the EEG. The parents are wonderful at helping keep the electrodes on. You need to prepare the child the best you can for the EEG, what's going to happen. Often you can get the electrodes on by distracting the child with the video, for example. They love to watch the same videos over and over again, many of the children. So you can get the electrodes on, and parents are very, really quite good at helping us keep the electrodes on. So we still do a lot of these patients as outpatients, so the child can go back to a more familiar environment as opposed to being in a hospital, which can be really stressful to the child. So we can usually get the EEGs done. I think a lot of it has to do with your techs, the people at the front line putting on the electrodes, how gentle they are with the child, and we do like to do that. We do not like to. Most parents do not want their child to be sedated for the EEG, and there have been certain situations where they're really concerned about the seizures that you actually use general anesthesia, but that's problematic because you can't. The EEG after general anesthesia is going to be slow and not very revealing. The best you can hope for is you get the electrodes on, the general anesthesia wears off, and you can get a few hours of EEG recording. But we try to avoid that. I mean, that's pretty invasive. But sometimes if the situation is dire, we need that information, we will do that. But that's not ideal.
Apart from general anesthetics, are there any other commonly used medications that might cause some artifact in an EEG tracing?
There are a number of medications like the drugs in the benzodiazepine families, clonazepam, diazepam, clobazam, that can be sedating and can lead to some changes in the EEG, but not that doesn't confuse us with it. It doesn't interfere with us detecting spikes and sharp waves on their EEG. The problem there though is that many of the children you try to pre-medicate and they have a paradoxical response. So if you try to give them clonazepam or benzodiazepine, like Valium, diazepam, that can lead to a paradoxical response where they become more agitated as opposed to sedated. So we try to avoid giving the children drugs if we can.
Are there some persons with autism or some persons without autism who have epilepsy exclusively or mainly during sleep? And are those different types of seizures, and what practical problems might that pose?
Yes, the individuals with autism that have seizures during sleep are usually pretty distinct. The most common type of seizure during sleep would be a tonic seizure, where they become very rigid, eyes open, which is a key component, stiff, less than 2 minutes in duration. There are always outliers. I mean, you can have, it can sometimes be difficult. You can have children with frontal lobe epilepsy that can look like a parasomnia. They can get up and have, we call them hypermotor seizures, where they can thrash around the bed and really look like a sleep disturbance, which in fact they're coming from frontal lobe seizures. And then that often comes down to clinical acumen, because even then the EEG is so filled with artifact, with muscle, that you have to sort of make that decision whether it's a seizure or not. You do the best you can, but it can be difficult. And in some situations, not often, we will try a seizure medication to see if that helps with these events, especially if they're occurring very frequently during the course of the week, even if we're not 100% sure whether they're seizures or not. But I'd say that's an unusual situation. But it can be challenging, not only in the children and adults with autism, but in the general population as a whole. There are some sleep disturbances, REM sleep disorders, that can really mimic seizures and vice versa. And the EEG may not be may not be as helpful as you had hoped it would be because of the artifact. But it can be tricky. Fortunately, those individuals are fairly rare.
And when you say artifact, you mean because of the moving around or frank thrashing?
Yes,
Yeah.
Exactly right.
And recognizing that every person is, unique, are there nonetheless some generalities that you as an expert in the field might be able to make in terms of similarities or differences in the management of epilepsy in persons with autism compared to persons having epilepsy who do not have autism?
Yes, I think that's very important, and that's true with a lot of other conditions that are comorbid conditions with epilepsy. For example, we see a lot of individuals with epilepsy that have depression, that have anxiety disorders, that have attention deficit disorder. And so there's certain medications that you would like to avoid in these patients because you can make those symptoms worse. Again, if you have a patient with depression and you treat them with benzodiazepines, such as clobazam or clonazepam, you can make the depression worse. You have patients that are quite agitated, anxiety. If you put them on drugs like perampanel, that can exacerbate the situation. Levetiracetam, a very popular seizure medication, can exacerbate the situation. So our individuals with autism that may have concomitant attention deficit disorder, anxiety disorders, OCD, you'd like to put them on medications that are maybe a little more mood stable and less likely to exacerbate the underlying condition. You just don't want to make things worse for the patient and make the treatment worse than the underlying condition. So in those patients, sometimes drugs like lamotrigine or valproate can be helpful because they're very good at mood stabilization. Gabapentin can sometimes be helpful in both, not a powerful seizure drug, but can be helpful in the anxiety component some of these patients have. So that's another choice. So you have to think very carefully about the side effect profile of these medications. It turns out that across the board, efficacy is fairly similar among the different drugs. They break apart with side effects, and there I think you have to sort of tailor your medication towards those patients' comorbidities. So we tend to treat children and adults with autism a little bit differently with our choice of medications than we do with patients that do not have autism. And you have to listen to the parents, caregivers, spouses, and take histories from them of what sort of changes they're seeing in the child or the adult with autism when you put them on the medication.
I see. And with your many years of working with patients and families who have autism and epilepsy and the clinical research that you've done, what do you now see as the major gaps in clinical knowledge and the major frontiers that need to be breached in clinical research relating to autism and epilepsy?
Yes, there's been some tremendous progress in autism, and I think in the area of genetics in particular, we've talked a little bit about most cases of autism have a genetic basis. And the issue there, though, is that there are over 50 genes that have been associated with autism, copy number variations. These genes do a variety of things: transcription factors, binding RNA. the genes that are involved in axonal transport, migration, genes that are involved in synaptic connectivity. Again, autism is really a neurodevelopmental disorder, so it makes sense that genes that are involved in structuring the brain may play a big component in whether you have autism. The challenge is that we have all these genes, and each single gene, we mentioned, ones that are more commonly associated with autism, tuberous sclerosis, Fragile X, for example, another one we didn't mention, a number of these conditions, but as a group, each individual genetic defect is counting for a very small percentage of the children and adults with autism. So we have to start thinking well beyond single gene leads to autism. And if we fix that gene, we're going to fix autism. It's not going to work. I mean, there are just too many things. So I think we have to, autism is a complex neurodevelopmental disorder, and we have to start thinking more on a systems-wide basis on how all this myriad of different gene defects at the end of the day leads to a phenotype that's pretty similar, that can be diagnosed by the pediatricians in 5 or 10 minutes. So the challenge is how to take all that genetic information and form a coherent idea on how those all come together, and at the end of the day result in that the child and our adult have an autism. So that's a real challenge, and I think then we get into the complexity of complex systems and trying to work on ways that we can modify this system that's already been formed, and how we can use techniques to modulate the brain connectivity. So there's a lot of work with transcranial magnetic stimulation, different ways to maybe modulate the way the brain talks from one area to the other. And there may be some pharmacological agents that can be helpful in that regard. And, in our lab and other labs around the country, we're trying to alter oscillations into correct autistic-like behaviors in rodents, using stimulation of certain key structures in the brain, using what's called optogenetic techniques, where you can just shine a light and actually induce brain rhythms that you want to induce, and then these brain rhythms travel throughout the brain. There's a lot of exciting things there. We're not going to be putting viruses in brains yet, but I think we're becoming very close to that. So I don't think we're going to, in autism, we're going to get too many therapies that are really gene-specific. And if we do, that's great, but I think that's only going to solve part of the problem. So I think we have to start thinking of fixing this abnormal neuronal circuit once it's already formed, and seeing ways to modulate that to help with the help these individuals with autism. I think we've I think another challenge is that there are certain therapies that work quite well, ABA therapy, and understanding how these therapies and the understanding, how they work and how that can help the child. What's the biology behind these approaches to the treatment of the children, and to turn that into other modalities to help treat the child. So we have a way to go. My view is that the genetics has been wonderful, but we're still in our infancy as far as understanding autism as a group by looking at all these single genes. We're going to be doing this for the next 100 years, and I think we got to move beyond that quickly.
Well, thank you very much. This is going to be of tremendous help to the pediatricians and family practice docs and internists who are hearing what you have to say. Thank you.
Yes, thanks.